Welcome to Fits on the Go ACC 2024. I am thrilled and excited to have Dr. Desai here with us today. He is Associate Professor at Brigham's and the Director of the Heart Failure and Cardiomyopathy Program. Welcome, and we're so happy to have you with us.
No, thanks for having me.
Yes. So today we would like to discuss with you a little bit about the Kardia 2 study that was actually... We heard the presentation this morning about it, and we're thrilled and excited to learn more about it from you. A little bit on a summary and overall results and anything you really want to tell us about the study.
Well, great. Well, let me give you a little context first, which is that although we all know that hypertension is an important problem, we sometimes forget that even though there are a lot of available therapies for hypertension, our efficacy in controlling blood pressure to guideline recommended targets has really not been very good. And if you look at clinical practice, any registry, large registry anywhere in the world, nearly 40% of patients with known hypertension are not controlled to the guideline recommended targets, and that is a lot of residual risk. So we need to do a better job. Zilebesiran is one novel approach to management of hypertension that's recently been developed. It is an RNA interference therapeutic that targets hepatic angiotensinogen. We're all familiar with the renin-angiotensin system, and this is another approach to renin-angiotensin system inhibition. But what is unique about this approach is that because it is an RNA interference therapeutic, the drug is administered infrequently and has a very prolonged duration of action, which has great advantages and has been deployed with efficacy in lipid management and other frames. So we have some data, early data with use of zilebesiran in patients with mild to moderate hypertension as monotherapy in patients with from the Kardia 1 trial who were randomized to treatment with zilebesiran and placebo. And in that trial, we saw about a 10 to 12 millimeter reduction in blood pressure at the 600 milligram dose compared with placebo that began early after administration of zilebesiran and endured to 6 months. And that reduction paralleled the reduction in serum angiotensinogen levels that are part of the mechanism of action of the drug. So for Kardia 2, which is the trial we presented just this morning, the goal was to understand the safety and efficacy of zilebesiran in combination with standard of care antihypertensive therapies. And the drugs that were chosen were a thiazide diuretic, a calcium channel blocker, amlodipine, and a high dose of a potent ARB, olmesartan, because these were thought to represent the common classes used in clinical practice. And the trial randomized patients after a run-in period during which they were exposed to one of these three background therapies to further treatment with zilebesiran, 600 milligrams as a single dose, or placebo. And then patients were followed for 6 months. The primary endpoint of the trial was the blood pressure reduction by ambulatory blood pressure at 3 months in zilebesiran compared with placebo. And then we looked at 6-month endpoints, with the caveat that at between 3 and 6 months, because we didn't want to leave patients untreated for too long, add-on therapy was permitted in both the zilebesiran and placebo arms. So that's the structure of the trial. The goal really to understand the effects of zilebesiran as add-on therapy in the study.
Yeah, it's amazing, and it's a new, exciting approach to managing hypertension with one shot every 6 months. So that's exciting, new approaches. Looking forward to hearing more about that. And I heard you mention at the end of the presentation there's a Kardia 3 trial. So where do you see the study going forward from that?
Yeah, so I think to give you a sense of, in summary, of the results of the trial, what we found was that at 3 months, patients treated with zilebesiran compared to those treated with placebo had incremental reductions in blood pressure, whether you measured it by ambulatory blood pressure or by office blood pressure. And those reductions were quite profound. Remember, we gave a potent dose of a thiazide, a good dose of a calcium channel blocker, and a very potent dose of olmesartan. And when the indapamide arm, the incremental reduction with zilebesiran was nearly 14 millimeters of mercury. Over amlodipine, 10 millimeters of mercury, and over olmesartan, 4 millimeters of mercury. And some are less impressed with the ARB reduction, but remember, this is one of the more potent ARBs on the market at maximal dose. So to see any treatment effect is really quite impressive. And then if you looked at 6 months, even after we allowed investigators to add on therapy, the differences in the indapamide and amlodipine arms persisted all the way out to 6 months, which means there was no catch-up. And even in the olmesartan arm, there was a difference in office blood pressure that persisted at the end of the trial. When we think about safety, which is a concern, you can give a long-acting anti-lipid agent with abandon, but we worry a little bit about long-acting antihypertensives because what happens if there's excessive blood pressure reduction? But fortunately, to date, we've really not, in the accumulated clinical experience, seen much serious hypotension. We did see adverse effects, the common ones you would expect to see with a renin-angiotensin system inhibitor. There was some mild hyperkalemia, some worsening renal function that was early, but much of this abated spontaneously and didn't require intervention. Now, I think when you ask about where we go from here, I think it's important to recognize that these are relatively short duration trials of heavily selected patients, and we need understanding of how this drug performs in higher risk populations, those with kidney disease, those on more medications. And that's really the goal of the Kardia 3 study, which is a study of patients with resistant hypertension on 2 to 4 medications who also have advanced chronic kidney disease and high CV risk. And I think once we have the data from that trial, I think we'll be well positioned to make a decision about what the structure would be of an adequately powered cardiovascular outcomes trial to see whether this truly represents an incremental advance over existing antihypertensives with regard to improving outcomes in patients with hypertension. So I think that's where the future hopefully goes.
That's amazing. Yeah. And what are your thoughts about medication adherence, given that's just one medication every 6 months? How do you think about that?
I think that's one of the great opportunities here, right? Which is that if we know that a big barrier to hypertension treatment is the fact that patients don't take medications quite as we intend them to. Sometimes that's not a willful thing, but it happens. And this is a strategy that is not linked to day-to-day adherence to medication. It's a one-shot approach, which you could imagine delivering in a clinic setting, much in the frame that we deliver immunizations, for example. And you could imagine at your Q6 month visits with your primary care physician, getting an injection and a treatment for lipids and for hypertension. So I think the paradigm of prevention might evolve if this proves to be a safe and effective strategy over the long term, but we need more data.
Yep. That will be groundbreaking and exciting to learn more about that. So thank you, Dr. Desai. To watch more videos like this, please check out youtube.com/fitsonthego, and you can follow us on Twitter @fitsonthego.